Welcome to this explainer. Today, we're taking the dense, sometimes overwhelming pharmacological world of cephalosporins and decoding it into a clean, easy-to-memorize clinical guide. If you've ever stared at a medication list full of complicated, similar-sounding antibiotics and just thought, no way, you are absolutely in the right place. Since their discovery way back in a Sardinian sewer in 1948, these drugs have evolved into a literal cornerstone of modern medicine. So we're going to take the confusion out of this massive class of medications and transform the raw data into a clear, actionable narrative you can take straight to the bedside or your board exams.
Okay, so here's our roadmap for today. We'll meet the cephalosporins, break down the 5 generations, look at side effects and toxicities, cover essential nursing management, and finally, go over those critical NCLEX alerts.
Let's jump right into Section 1, Meet the Cephalosporins.
At their core, what are they? Well, these medications are bactericidal beta-lactam cell wall synthesis inhibitors. Let's break that down just a bit. Bactericidal means they don't just slow the bacteria down, they actively kill it. They do this by binding to specific penicillin binding proteins and inhibiting the cross-linking of peptide glycan. Now, think of peptide glycan as the mortar holding the bacterial cell wall's bricks together. Without it, the bacterial wall becomes fundamentally unstable. As internal osmotic pressure builds up, the cell literally bursts open and dies. It is a highly effective, super-targeted mechanism.
Now, to quickly spot them on an exam or a patient's chart, you just want to look for that identifying Ceph or Ceph prefix. You know, pattern recognition is your absolute best friend in pharmacology, especially when you're running on fumes during hour 10 of a 12-hour clinical shift. Whether you're looking at cefazolin, cephalexin, cefotetin, or ceftriaxone, that simple prefix instantly tells you that you're dealing with a beta-lactam cell wall inhibitor. And once you spot it, you immediately know the mechanism of action, and you can instantly start anticipating potential side effects before you even walk into the patient's room.
Moving right along to Section 2, the 5 generations.
Treating this drug class like a series of software upgrades across 5 distinct phases is honestly the most powerful way to memorize them. Because they weren't all created at once, right? They evolved. Think of Generation 1 as the reliable, original software. It gives you a solid, gram-positive baseline, great for your common staph and strep infections. Then, Generation 2 rolls out a much-needed patch with better gram-negative coverage. By Generation 3, we get the crucial blood-brain barrier patch, suddenly allowing these drugs to fight severe central nervous system infections. Generation 4 expands the coverage dramatically into a really broad spectrum, targeting highly resistant, hospital-acquired bugs. And finally, Generation 5 is the ultimate unlock, specifically engineered with the heavy artillery to take down MRSA.
And here's where it all comes together, because we can perfectly match specific drugs to their specialized clinical jobs. For the first generation, cefazolin is the absolute gold standard for surgical prophylaxis, protecting patients right before the scalpel even hits the skin. Jumping to the third generation, drugs like ceftriaxone and ceftazidime are our heavy hitters. Since they easily cross the blood-brain barrier, they're the go-to life-saving treatments for severe meningitis, as well as stubborn cases of gonorrhea. Then the fourth generation gives us cefepime, which is a broad-spectrum powerhouse frequently deployed for critical, immunocompromised conditions like febrile neutropenia. And rounding it out, our fifth-generation hero is ceftaroline, stepping up to the plate when we face a severe, resistant MRSA infection and our standard options have just flat-out failed.
All right, let's talk about the downsides in Section 3, side effects and toxicities.
Because both classes are beta-lactams, there is a 5 to 10% cross-reactivity allergy rate between cephalosporins and penicillins. They share a very similar chemical beta-lactam ring structure. So what does this mean for us? It means if your patient has a documented, true anaphylactic allergy to penicillin, there is a statistical chance their immune system will look at a cephalosporin, see the exact same enemy, and trigger a massive allergic response. This piece of data absolutely needs to live rent-free in the front of your mind during every single medication pass.
Beyond that cross-reactivity, general hypersensitivity, things like rashes or fever, occurs in up to 16% of clients. Now, while 84% of patients tolerate these medications beautifully without any reaction at all, that 16% is clinically huge. It tells us that allergic reactions, ranging from a mild macular rash or drug fever all the way up to life-threatening airway compromise and anaphylaxis, are common enough that you just have to remain highly vigilant, especially when you're administering that very first dose.
You also really need to watch out for the quirky exceptions. Like all broad-spectrum antibiotics, they alter normal gut flora, which brings a well-known risk for C. diff. But the specific drug toxicities are what's really fascinating here. Cephalosporin, a second-generation drug, has a unique chemical structure called an MTT side chain. This side chain actually depletes prothrombin, which significantly cranks up bleeding risks. Then you have ceftriaxone, which has this notorious habit of binding with calcium to cause biliary sludge, leading to severe gallbladder pain. And if you've got a patient with failing kidneys who is receiving abnormally high doses, these drugs can accumulate in the bloodstream and actually lower the seizure threshold.
This brings us to Section 4, Essential Nursing Management. So your standard monitoring absolutely must include renal function labs, IV site checks, and specific clotting labs if the patient happens to be on cephalosporin. Because these drugs are primarily excreted through the kidneys, tracking the blood urea nitrogen, or BUN, and serum creatinine, which are your standard markers for kidney health, is completely non-negotiable. If those numbers start climbing, the dose might need a quick downward adjustment. And hey, if you're administering cephalosporin, remember that prothrombin depression we just talked about? You need to keep a really close eye on their prothrombin time and INR to make sure their blood is still clotting properly. On a practical level, these drugs can be incredibly irritating to veins and muscles, so rigorous IV site inspection for phlebitis, making sure you have proper fluid reconstitution, and rotating injection sites, these have to be daily nursing priorities.
Now check out this number. It typically takes 48 to 72 hours to see an initial therapeutic response, like a noticeable drop in a fever or a normalized white blood cell count. This is a crucial piece of education for both you and the patient. We are not expecting a miraculous overnight cure in 12 hours. We have to give the medication 48 to 72 hours to achieve steady-state concentration in the tissues and actually start winning the biological war against the bacteria. Bouncing around and changing antibiotics too early just because it's not working fast enough is a really dangerous practice and a fast track to creating untreatable antibiotic resistance.
But before you even hang that IV bag or hand over a single pill, ask yourself, what is the absolute first thing you must check? You've got your physician orders, your baseline labs are perfectly drawn, your patient is totally prepped, but there is one gatekeeper question you must ask every single time.
And that leads us perfectly into Section 5, Critical NCLEX Alerts. The answer to our little gatekeeper question is this strict, completely non-negotiable rule. Always thoroughly assess the allergy history for both penicillins and cephalosporins to avoid severe reactions. You can't just casually walk in and say, "Hey, are you allergic to anything?" No, you must explicitly ask about penicillin and cephalosporins by name. If the patient tells you, "Oh yeah, penicillin gives me a severe rash and makes my throat itch," you immediately stop, withhold the medication, and notify the provider before taking another step. And we do this solely because of that 5 to 10% cross-reactivity risk.
Also, you need to be incredibly clear with client education, because combining some of these drugs with alcohol causes a severe disulfiram-like reaction. This is especially true for cephalosporin. If a patient knocks back a drink while on this medication, they are going to quickly experience violent nausea, projectile vomiting, intense facial flushing, and throbbing headaches. You must heavily educate them to avoid all alcohol, and I mean including hidden sources like certain sauces, cough syrups, or mouthwashes. Trust me, that is definitely not the way your patient wants to find out their mouthwash contains alcohol.
Finally, you have to ensure patients know to complete their entire course of therapy and to immediately report severe diarrhea, which could obviously indicate a C. diff infection. You know how it is. Patients love to stop taking antibiotics the exact second their throat stops hurting. You have to explicitly explain that stopping early just leaves the strongest, most resilient bacteria alive to multiply. Furthermore, they need to know that severe, watery diarrhea isn't just a normal stomachache, it's a critical medical alert for pseudomembranous colitis. Also, advise them to watch out for joint pain and fevers occurring several days later. This could be a delayed serum sickness-like reaction, which is an immune response that happens days after exposure, making it extremely easy for patients to just completely miss the connection to the antibiotic they took.
To wrap up this explainer, I want to leave you with a real-world clinical scenario to ponder. If your patient has a life-threatening penicillin allergy, why exactly is hitting pause before hanging IV cefazolin the most critical move you can possibly make? Well, the answer lies in everything we've unpacked today. Cefazolin is a first-generation cephalosporin. Because of their shared beta-lactam ring structure, that patient's immune system might react just as violently to the cefazolin as it did to the penicillin. Understanding these fundamental relationships and molecular mechanisms, that is exactly what separates a good student from an exceptional clinician. Keep studying, keep making those connections, and I'll catch you in the next explainer.